Hi everyone, my name is Melanie Staley and I'm a consultant clinical psychologist and I work for the Psychological Skills Service. I'm going to make this recording today to try and explain the new guidelines on the treatment of complex PTSD and how it affects us. And when I say us, I'm going to be talking mainly about the Psychological Skills Service, talking therapies and secondary care. So as some of you will know, there's been some recent new guidelines about the treatment of treating PTSD and complex PTSD in mental health services. Previously, there was an approach that talking therapies should see people for single incident trauma. The new guidelines says no, actually talking therapies should also be seeing people with complex PTSD. So we, as in myself, the leads of talking therapies and secondary care, have got together to think really what does this mean. So now all three of us are seeing people with complex PTSD. How do you as referrers know who to refer to each service? So we have produced some guidelines which will hopefully give you some indication when you've got someone in front of you, which service should you signpost them to. In order to do this properly, I'm going to give you an overview of the guidelines themselves, changes in the diagnostic criteria for complex PTSD that underpin some of these changes in guidelines, talking a bit about what we actually mean by treatment of complex PTSD and differentiating between complex trauma and complex PTSD, because there's often quite a lot of confusion. I think people often talk about people suffering from complex trauma and get the terms PTSD and trauma confused. So I'm going to talk about how complex trauma is the thing that happens, or the experiences that people have. The complex PTSD is one of the consequences of exposure to complex trauma. I'll briefly touch upon some of the other consequences of exposure to complex trauma that need to be understood in assessments, and a little bit about the treatments and how the three different services offer different things, and how you would know whether somebody should be referred to one or the other. So we've produced some guidelines. I will show that that's a Word document. I'll show you that after this PowerPoint, and you'll be able to find this document on our website. So key principles of the guidance that we've produce. So when I talk about that later, when you're assessing someone and you're trying to decide, so A, do they have complex PTSD? If so, where should I refer them? We're going to talk about needing to consider the level of disturbance, not the severity of trauma, to determine which service to refer to consider the number of re-experiencing memories, not the number of traumas. So there's a common misunderstanding that when you have trauma therapy, the therapist is going to try and process all of the traumas. That's not the case. The therapist will only process the memories that we see as stuck, and the memories that we see as stuck are the ones that are directly related to the intrusive symptoms, so the flashbacks and the nightmares that someone's having. If someone isn't having flashbacks, nightmares, or having emotional triggers, or feeling like they need to avoid certain situations, so if the past event is not impacting on the present, then there's no need to process that memory. So it's important that in our assessments we try and understand how many past events are impacting on the present, because that will determine the number of sessions, and that will also help us to decide which service is most helpful, because talking therapies can offer less sessions than other services. We need to consider risk and the amount of stabilisation and preparation a person will need before they start specific reprocessing work, and whether a person needs an MDT around them. So are there things, are there other consequences of exposure to complex trauma that are impacting on an individual, and do these other things need addressing concurrently? So does this person need other people to be working with them? Okay, so what's triggered a review of the guidelines? So there's been a change in the diagnostic criteria. So the ICD-11 definition of complex PTSD is no longer aligned with DSM-5. So what ICD-11 have done is they've made PTSD a bit narrower than it was before. So previously, PTSD in ICD-11 used to include a belief that there's something bad about you, and difficulties in emotional regulation, as well as the things we think of as PTSD. So re-experiencing memories as if they're in the here and now, avoidance, hypervigilance, exaggerated startle response. So ICD-11 have decided to take out those two extra bits and just say, well, actually, PTSD is just the re-experiencing symptoms, so the flashbacks, nightmares, avoidance, etc. And they've then called complex PTSD plus difficulties in emotional regulation, difficulties with relationships, and difficulties in, or I guess a core negative sense of self. So a belief that there's something really bad about me. So the two of those things used to be included in ICD-11 PTSD. So that's important, because it means that some of the people who now have a diagnosis of complex PTSD would have previously, in the old criteria, just had a diagnosis of PTSD. So it's likely that talking therapies won't be seeing people that different from the people they've been seeing before, because when they use the old criteria, some of the people who now have who meet the criteria for complex PTSD would have previously had a diagnosis of PTSD. And there's still and there's also still the emphasis of the same therapies. So the therapies that are indicated as effective for PTSD have the same have an equivalent evidence base for complex PTSD. Because don't forget, complex PTSD includes PTSD. So, and actually, they've trauma-focused CBT, which is one of the NICE guidance treatments for PTSD, has been found to have a larger effect size for people with complex PTSD. So we're not really stating we're not changing the things that we would offer people, but there's just been a slight change in the diagnostic criteria. So I've put a little note here because it's really important to remember that people don't suffer with complex trauma. So we get a lot of referrals to our service that say this person suffers with complex trauma. Complex trauma is the experiences that someone has had in the past. PTSD and complex PTSD are one of the consequences of exposure to complex trauma. Basically, in PTSD, the theory is that for different reasons, a person's brain hasn't been able to process memories and put them in the right place. So they're stuck in a part of the brain, which we think is called the amygdala, where they're quite easily triggered, experienced as fragments, and easily triggered in the in the here and now. So that's one of the ways in which trauma can affect people, but not all of the ways. And when we're talking about treatment here, we're specifically looking at the treatments for PTSD and complex PTSD, but it is important to remember that in a thorough assessment, we need to really understand what are the other consequences, that how is the trauma a person has experienced affected them, because there will be different treatments indicated depending on what the difficulties are. So there are lots of, these are only some of the ways that complex trauma can manifest itself in an individual. So there's been found to be a relationship between trauma and PTSD, psychosis, problems associated with a personality disorder diagnosis, so difficulties in regulating emotions, difficulties with attachments, difficulties in coping with distress. There's lots of research to show that exposure to developmental trauma leads to changes in brain structures, including the hippocampus and the prefrontal cortex, that are involved in being able to soothe and regulate yourself, in empathizing and being able to problem solve. There's evidence that shows that people who are exposed to complex trauma have lower levels of quite key neurotransmitters like serotonin, dopamine, cortisol, neurotransmitters that are involved in soothing, in sleep, in a sense of pleasure, in that experience of get up and go. There's physical problems that are linked to prolonged cortisol release, which is what you see in complex trauma. Trauma has been linked to bipolar disorder, functional neurological disorder, chronic pain, fatigue, anxiety, eating disorders, and a variety of other and there's lots of physical health problems that have been found to be related to exposure to trauma, like heart disease. So when we're thinking about, so people don't suffer with complex trauma. Complex trauma can lead to an awful lot of suffering in different ways. It depends how a person's brain has made sense of it, and lots of other environmental factors. So the guidelines focus on how trauma affects complex PTSD. So just as a just going back to the criteria, the ICD-11 diagnosis of complex PTSD consists of 6 symptom clusters. These include 3 post-traumatic stress disorder criteria. So you can't have complex PTSD without having PTSD. So re-experiencing of trauma, avoidance of trauma memories. That includes dissociation, so physical and psychological avoidance, and a heightened sense of threat, difficulty sleeping, increased irritability, hypervigilance, plus evidence of what is called a persistent and pervasive disturbance in self-organization. This, broken down, includes emotional dysregulation, so frequent mood changes, difficulties coping with emotion, self-destructive behavior, and dissociation. So exposure to lots of trauma impacts on brain structures and chemicals that are involved in regulating emotions. People have a smaller window of tolerance. That can be one reason why people struggle to cope with emotion. They just have less ability to tolerate and cope with emotions. People haven't learned strategies because of the trauma they've experienced, and quite a lot of people have emotional flashbacks, and so those kind of overlap with both criteria, where something in the present gives them a feeling memory, so the feeling is more extreme than we would assume would happen in the present, and and so a person has an extreme emotion, but that's maybe because that emotion is a flashback to the past. Interpersonal difficulties, so difficulties feeling close to others, consistent avoidance and lack of interest in social engagement, occasional experience of close, intense relationships, but difficulties in maintaining engagement. This is different to the interpersonal difficulties we often associate with emotionally unstable personality disorder. People are more likely to maintain a distance from other people and struggle to stay close to them. So although people often try to make sure they're trying to please people all the time, because that's a strategy to avoid being hurt or rejected or abused by people. So people will be in a relationship and give up all of their needs and sacrifice everything to please another person, but actually emotionally it's very hard for people to connect with and trust another human being. And a negative self-concept, a belief that everything is their fault or there's something bad about them, and a real pervasive feeling of guilt and shame. I quite like this diagram because it just gives a nice visual representation. So there's the PTSD symptoms plus difficulties in affect regulation, a negative self-concept and interpersonal disturbances. I'm sorry about the writing here. As I said earlier, complex PTSD is one consequence of exposure to complex trauma. Just to go back to, I guess, what actually is complex trauma. So complex trauma is when people are exposed to a stressor of an extreme or prolonged nature from which escape is difficult or impossible. So this could be torture, concentration camps, slavery, forms of violence, domestic violence, and childhood sexual, physical abuse or prolonged neglect. Importantly, for me in assessments, what you're thinking about is situations where a person's threat system has to stay on. So our threat system is designed to go on and then switch off. But actually, if you're in a situation where you can't escape the danger, your threat system has to maintain permanently on. So quite a good gauge of whether this was the case for someone is asking the question, during your childhood, did you ever feel safe? And often people say no, and this is a bit of a rough guide as to whether they were people whose threat system had to stay on. So here's a little diagram, so you can see the dark blue circle in the middle that shows where complex trauma fits in trauma. So things that are covered in that category: chronic life-threatening illness, domestic abuse, sexual abuse, torture, trafficking, witnessing parental violence, military trauma, emotional abuse, physical abuse, and sexual abuse in childhood. And I've put a little addition there in green, which I've linked to it, about sensory sensitivities, social communication difficulties. If you're someone who struggles with understanding social cues, is highly sensitive to sensory stuff, then that makes a lot of just average things quite traumatic, particularly if you're in an environment where people aren't able to understand that. So people who are neurodiverse might be more likely to have a threat system that needs to stay on, because things are even harder. That's when they're in an environment where their challenges aren't understood and accommodated. It means that everything is harder. So guidelines for the treatment of PTSD. This is just the standard PTSD. So the therapies that are recommended are cognitive processing therapy, cognitive therapy for PTSD, prolonged exposure EMDR and narrative exposure therapy. This is particularly indicated for refugees with multiple traumas. So NICE says that if someone has complex PTSD, and these guidelines were written quite a while ago, you should treat it as you would straightforward PTSD, but also build in extra time to develop trust with the person. And this could mean increasing the duration or the number of therapy sessions. Take into account the safety and stability of the person's personal circumstances and how this might affect engagement. Help a person manage any issues that might be a barrier to engaging with trauma-focused therapy, such as substance misuse, dissociation, emotional regulation, interpersonal difficulties, or negative self-perception, and work with the person to plan any ongoing support. They don't give specific guidance as to whether those things should be done before or concurrently, but there's an indication that we have to think about those additional factors. So I'm just going to go over quickly some key points that I've talked about before. Okay, exposure to complex trauma does not just lead to PTSD, therefore all good assessment need to understand how experience of complex trauma has affected the individual and not just assume they have PTSD. So don't refer people for EMDR or trauma-focused CBT if they don't have PTSD. There's not an evidence base for those treatments for any other problems. This is important because different therapies are indicated for different consequences of complex trauma. So trauma processing is only indicated for PTSD, and here's a little diagram which you may or may not be able to read. But in our service, we try and think in our formulations, how has a person been affected by trauma and what kind of therapeutic approach is going to be helpful or indicated for the way they've made sense of their difficulties and what they're struggling with. So as a consequence, we offer compassion-focused approaches, ACT, CBT, CBTP, trauma-focused CBT, schema therapy, because there are lots of different ways that a person can be affected, and it's really important that we understand for that person what's been the biggest impact of what they've experienced, so that we can give them the therapy that's going to be most effective. So if someone has really strong core beliefs that continue to get triggered in everyday life, particularly in relationships, and they have long-standing maladaptive ways of coping that impact on their relationships, their well-being, perhaps schema therapy is a more helpful therapy and is indicated by a formulation, and in that case EMDR is not going to be as effective. And we also need to consider the timing of interventions. Bruce Perry, who's a psychiatrist, talks about rebuilding the brain in the right order. So this is particularly relevant if the complex trauma took place in childhood. So our brains are developing until we're 25, particularly in the early years of childhood. That's when our prefrontal cortex and our hippocampus and other higher order brain regions are being built. So if people are exposed to high levels of threat in those early years, the development of those brain areas will be impacted, and people will have underdeveloped parts of their brain, in effect have brain damage. And what Bruce Perry talked about is, we need to make sure that we help people to have to rebuild the parts of their brain in the right order. So you have to think, how has this person been affected, what they need first. And NICE also supports this. It also says, we need to manage any issues that might be a barrier to engaging with trauma-focused therapies. Lots of diagrams here which reinforce this idea. You've got Maslow, who I think is an important person to always go back to, we have to meet a person's basic needs before their psychological needs, before they can do sense making. Bruce Perry talks about how a person needs to be able to regulate before they can relate to another person, including a therapist, before they can reason. And this is just a diagram from the ACEs study, which probably should have come earlier, which I think was there to explain how trauma has many different consequences. So these diagrams reinforce some of the things I highlighted earlier about the relationship between ACEs and neurodevelopment, physical problems, addictions, voice, hearing, depression, chronic fatigue, PTSD, difficulties in empathy, negative self-beliefs. Okay, so I'm going to talk a little bit more about the therapies that we're talking about. So I'm assuming if you're watching this, you're interested in referring people who have complex PTSD to talking therapies or the psychological skills service or secondary care for one of the trauma processing therapies. So I'm assuming now in your assessment you think, right, okay, this person definitely has complex PTSD, and there's a questionnaire that can help you with this, and I've mentioned this in our Word document diagram called the International Trauma Questionnaire. You can download it. Will save you lots of stress. You just ask the person the questions on this questionnaire, and this will give you a score to tell you if a person has complex PTSD and how much it impacts on them. So rather than you having to think about the questions yourself, but you've assumed that, and you're going to now refer to one of these therapies in one of these services. So I just thought it was helpful to tell you what they involve, really. So just once again, they only have an evidence base for treating PTSD, nothing else. I've spoken earlier about how we need to figure out how much stabilization a person needs. So does this person, before they start doing specific work on reprocessing, and by reprocessing we're looking again at the memory in more detail so that we can re-examine it and our beliefs about it, put it in the right place. But there's lots of talk about maybe some people need some stabilization work first, and there's lots of controversy about this. And one of the questions is, well, are we not just prolonging treatment by putting people in stabilization groups or assigning things like support work or anxiety management? So I'm going to say no, because I guess if you've trained in one of these therapies, what you know is that both of them have embedded in their protocols some stabilization work. So it's actually part of the protocol. When you learn how to do these, there's phases that you do in each of these therapies. Stabilization is one of them. EMDR has 8 phases actually, and one of those phases is preparation, and in that phase you're helping someone to build the necessary resources that they need to be able to cope between the sessions. And so the preparation phase talks about the importance of people feeling safe. So EMDR intentionally activates the nervous system. This might bring back terror or flashbacks. So people usually report more nightmares, more intrusions between therapy sessions. So it's important that people have the ability to break. So we're teaching them to accelerate. You need to know, to be able to carry on with your life between the sessions, how to put the brake on, how to ground yourself in the present. People need to be able to start any kind of processing it in a calm, neutral state of mind. So they need to have the skills to be able to do that. So the preparation phase of EMDR can take 1 to several appointments. In these sessions, people learn to calm and balance their nervous system, and people are taught specific skills, for example, a safe place or container exercise. This would normally be part of EMDR anyway. So how long does preparation take? Well, there's something called the continuum of complexity, and so if people have had a lot of complex traumas, they've had multiple traumatic experiences that have impacted on their early brain development. So they're the people whose certain parts of their brain are underdeveloped. So it's really hard for them to stay present and to soothe themselves, to rationalize. This means that preparation for EMDR can take 1 or 2 sessions, but it could take weeks, months, and sometimes years. So a therapist is told to not start reprocessing if a person isn't ready. So the continuum of complexity. So this is in the EMDR manual. We're taught to think about how much, that there are some things that we look for to think about the length of stabilization a person might need. So things that might indicate the need for longer stabilization or preparation are evidence of lots of difficulties with affect, and so being able to label emotions, detect emotions. So a lot of people are alexithymic, can't identify how they feel, and therefore struggle to regulate how they feel. Difficulties individually and relationally, easily triggered into high arousal states by daily life events. Difficulties with impulsivity. Dissociative symptoms that are disruptive to self and others. So and limited external resources. So when you talk to people, who do you go to for support? Duty is what they say, because actually they don't have many people to offer support sessions, and there's evidence of self-injury, addictive behaviours, suicidality, violent urges or actions. And then the goals of stabilization work are to increase window of tolerance, increase ability to self-regulate, manage current triggers through development of adaptive coping responses, increased ability to shift states, increased ability to track emotional and somatic responses, increased capacity for mindfulness. So do I actually can I observe what's going on for me in a way where I'm not overwhelmed by that, so I can think about what I need, and strengthen the sense of safety and confidence in themselves. So our trauma stabilization group covers skills in these areas. So if we think that a person is a person who's quite far along the continuum of complexity and needs a longer preparation phase, what we've done is, rather than say the therapist who's providing the trauma processing spends sessions and sessions doing this, we say actually these are people who will refer to a group program first, because they're going to need longer input, more sessions to build these skills. Trauma-focused CBT also involves more than just processing. So when you look at what's involved in trauma-focused CBT, grounding and stabilization is part of trauma-focused CBT. So people are, as part of their therapy, given skills to practice techniques. This might include relaxation or other techniques to stay grounded. Yes, it also includes working with memories. It also includes working with beliefs. So building compassion, thinking about their reactions and how their experiences impact on sense of self, and why a lot of people experience shame, and then how people can reclaim their life. So it's important to recognize that there are extra elements in trauma-focused CBT that aren't just working with memories. And again, we might think, well, if someone needs a longer period of time to learn grounding and stabilization techniques, because again, there are parts of their brain that are underdeveloped and they haven't learned how to do this, that they don't know how to recognize their emotions, that they are easily triggered, then a group might come first, or maybe somebody needs some specific anxiety management strategies, or they need help with managing some of the stresses in their daily life which continue to push them out of their window of tolerance, making it difficult for them to be able to attend all the sessions. So back to the guidelines. Aims for our guidelines. Once you've established that a person has PTSD and has goals related to this, we need to decide which service to refer to. So we've created a set of guidelines that thinks about the number of memories that they might need to be targeted, how problematic the difficulties of self-organisation are, as well as their PTSD symptoms. So how much of the person struggle with emotional regulation, relationships, and a negative self-belief, how much preparation or stabilisation a person is likely to need, risk to selves, and need for other input to stabilise in environment. All this stuff is in there. Is echoes some of the stuff in the guidelines. And these are a reminder again of some of the key considerations. How many memories appear to be unprocessed and intruding on the present? So when someone tells you about their flashbacks and nightmares, ask about them. So is it one thing is it one incident that you have a flashback about, or are there multiple things? Are there multiple situations that trigger this sense that you're in danger now, and are those linked to the same thing or different things? This is really important to help us figure out which service is going to be helpful, and what are the other consequences of trauma that impact on that they're impacting on a person. Okay, so I'm going to stop sharing that right now, and I'm going to just share for you briefly, but I think it's probably more helpful for you to have a look at these guidelines. So what we've done is we've made columns that say talking therapies, PSS, COLT, and it asks questions about does a person meet the criteria for PTSD? That's a yes from all of them. The severity and the impact of trauma. I've included in this Word document the International Trauma Questionnaire and the PCL5, which for some reason I can't remember the actual full name of that now. The International Trauma Questionnaire is a checklist of complex PTSD. You can use one of these checklists, these questionnaires, to help you decide whether a person has PTSD and whether the level of severity is high enough. Okay, so then there's some questions about the timing of trauma. So what we're trying to figure out here is there are some questions that help to think about how many sessions is this person likely to need. So there are some specific questions about the timing of the trauma and number of perpetrators, which helps you to gauge who might need longer in therapy and perhaps a period of stabilization. So as an example, in talking therapies, a person is going to need the trauma is more likely to have occurred in adult life, and people are more likely to report some healthy relationships, whereas people who might be more suitable for PSS, who might need longer treatment and some stabilization work, or even consideration of other factors, we expect their traumas originate in early childhood during a developmental period, and there are a number of traumas and perpetrators that contribute to flashbacks and few healthy relationships. And in secondary care, it's unlikely that a person ever really felt safe. I've talked in the guidelines about about there being about thinking about the number of traumas that are contributing to flashbacks. The impact of the other factors, the other parts of complex PTSD. So you've got PTSD plus those disturbances in self-organization. If someone is struggling with or reports a lot of difficulties or interference related to a negative self-concept, relationships, and difficulties in emotional regulation alongside PTSD, it might be that PSS might be more suitable. And if those difficulties have an extreme impact, so a person is quite disabled by them, then secondary care might be better indicated. You can use the ITQ to help you with this. I've talked a little bit about the likely preparation. Hopefully from the PowerPoint that makes a bit more sense. Dissociation, we would expect people who require secondary care to be highly dissociative. That might be one of the key things. So a person really struggles with dissociation, so and that has a huge impact, so might need a longer period of engagement. You might expect some of that in PSS and less of that for talking, if you're referring to talking therapies. Risk is there for, this is very hard to move up and down. So if someone has recently had, is reporting suicidal ideation, recent attempts, struggles to keep themselves safe without support between sessions, then secondary care is indicated. So a person's likely to have had a history of acute care contacts and inpatient admissions, and limited reasons for living and protective factors. PSS, we would say a person might have suicidal ideation but no intent or plan to act on these, and that there's evidence for reasons to live, and risks are likely to be historical, so they're able to be managed in the primary care system. There are some other complicating factors I'll just go over that might mean that we assume that the number of sessions might need to be longer. So a need for interpreters, comorbidity of drugs and alcohol. So a person is stable to engage but might need longer sessions. And what we found is neurodiversity can mean that a person is likely to need longer sessions and more sessions, because some of the techniques are harder. Lots of people really struggle to imagine safe places, and we have to use more creative ways to help people to ground themselves. Often it's quite hard for people to process memories because they get very hooked on detail, so sessions are longer. So those factors might mean that we need to offer more sessions. If you're unsure, you can always bring to one of our interfaces. So we have interfaces with talking therapies and secondary care. For this is on Monday for Peterborough, Friday morning for Cambridge at 10 o'clock, and then for the central team you've got at 1 o'clock it's a meeting with Huntingdon, and 2 o'clock it's Fenland. So please get in contact with us if you want to discuss. So I'm going to stop recording now, but I do hope that this has been helpful to you and helps you to understand the differences. I'm going to put the slides and the Word document on the website as well, so it should be in the resources section if you want to consult it. Thank you.